Thank you very much, Dr. Dalia, for a very excellent presentation of an interesting topic. Thank you very much. And now we have short time for discussions and questions. If Dr. I will start by the first presenter, and if he's around, and I received some questions here related to the lecture about rickets. Is the doctor around? Well, he's not there. He's the one who gave the first presentation. If not, we can have questions for Dr. Dalia then. Okay. Dr. Dalia, in your practice, what is the most common kind of side effects you have seen in your patient over these years of growth hormone therapy?
Assalamu alaikum, Doctor. Good afternoon, everyone. It's a pleasure to join you here at the Q&A session. Thank you very much for listening to my talk. Now, in my practice, the most common, as I said in my talk, growth hormone is one of the safest medication I use in our pediatric endocrine clinic. And the most common side effect that we see from growth hormone therapy, especially at the start of therapy, is the local side effects. As the families learn how to use the growth hormone, use the pens, they get a lot of bruising, bleeding at the site. And this is one of the commonest side effects that we get from growth hormone therapy in these kids. And thankfully, as the families and children, they get used to the medication that they experience giving the injection on daily basis. After quite a while, this side effects lessens usually, and we don't get a lot of local side effects at the site of an injection. So this is the commonest I see in my clinic, basically.
What about like headache due to increased intracranial pressure and the gynecomastia? Because in our practice, these are like scaring side effects for our patients.
Yes, these are more severe side effects of growth hormone therapy, but thankfully with proper follow-up and proper education about with these patients, these are the most serious, but they're not the most common. We see these. I have seen this 2 or 3 times in my practice in our endocrine clinic with regards to increased intracranial pressure. We've seen till now a couple of kids with allergies. And the third that we also seen is advancement of scoliosis. And that's why during our follow-up in these kids, we always examine the child for scoliosis. So these are serious side effects, but they are less common compared to the local.
I noticed that you didn't mention cost as a limiting factor for the compliance or the use of growth hormone. In Kuwait, do you give this treatment free for all patients?
So yes, let me just, I didn't go over it in my presentation. So in Kuwait here, the policy in terms of funding growth hormone therapy for those who qualify for the criteria is it's free for all Kuwaitis, and non-Kuwaitis, they will get help from the Patients' Aid Department in the Ministry of Health, depending on the family's financial situation. And this is for non-Kuwaitis. This is how we do it here in Kuwait.
Oh, thank you very much. I think this is why your program is successful. Okay, another question from Professor Wiam, please.
Dr. Dalia, that was an outstanding talk. Thank you so much for being with us. This is Wiam Hussein. I am an adult endocrinologist, and what we face actually in practice is people coming to us with their kids 2 years or more after puberty to be seen by adults, and they don't really have an indication except idiopathic short stature. And the family is willing to pay their cash, and they were willing to try for at least a year or 2. What's your take on that?
So yes, this is very common, Dr. Wiam. We face it here as well. And as you've seen from our study, fifth of our referrals to the endocrine clinic for the indication of short stature is unnecessary. These kids are normal in growth, and there is a lot of lack of public awareness about normal growth. And as I said, there's a lot of pressure for them to be taller. It's considered more active, more powerful, more trustworthy. Now, the way I do it is in our public clinics, in the public. Now, if the child is not qualifying the criteria for short stature, he does not qualify for a growth hormone. And there is usually, as I said, the older the child, now we don't have any studies about growth hormone response in of children with normal stature. So I don't know if growth hormone in a normal child who the FSCs did not close, I don't know the response to it, if it will give them the extra centimeters that they seek. So in the government, of course, it's not funded for this, so we don't really, we face a lot of pressure by the families, and it is really challenging to educate these families. Now it will be more challenging for the adult endocrinologists because these are after puberty, the epiphyses have closed, and for certain there is no response to growth hormone at that time. However, I see that there, I'm not sure how it is the situation in Bahrain. In Kuwait, also growth hormone is provided commercially and privately. So they can get a growth hormone for their kids, and they can buy, some families, they can buy it from outside. However, I don't practice in the private sector, so I don't really know the response of normal kids who are on growth hormone. There is no studies because it's not funded for this indication. So I don't know what is the response, and I don't really recommend it. It's a daily injection, and you will be labeling your child as being sick. The child will, I don't know, if a child is normal, why giving him an injection daily as if he is sick? So it has to me, it is, it's not indicated. It might affect the child on a psychologically. He will perceive himself as being sick. So I think the most important thing is educating the public, is that what is normal growth, and there is a wide range for normal growth in children. There are children who are shorter, but they're normal, and there are kids who are taller, but they're normal. But by the end, all of these are healthy children, and they will grow normally and achieve their potential normally.
I think I do agree with you 100%, and I don't think there is any real indication to use growth hormone in normal children. Another similar problem is when there is no real indication or approved indication for growth hormone, like genetic cert state share and all this, and the parents insisting on having a trial of growth hormone. And many people talk about why not to give them a trial for 1 year and see if there is any response. But I think still this may not be ethical or not medically correct. I do agree that we should stick with the indications, and this is an important medication we can use for these children. Of course, our colleagues, adult endocrinologists, they have other indications, and always they will find the room to use growth hormone for different kind of things, like, as you said, old age, improving energy, muscle strength, keeping youth, I don't know, different things. But for us as a pediatrician, we really care for children. One of the difficulties I face personally in practicing growth hormone treatment is when the children present late, actually just in the pre-pubertal age. And then you start your growth hormone, and you don't know really if the response is growth hormone or this is the normal pubertal growth spurt, which is expected to occur with commencement of the puberty. So you cannot really differentiate which of which, yani. Are you really getting this response because of the growth hormone, or this is the natural pubertal development at this age? So it is difficult to judge. In younger children, it is more easy. What is your impression about that?
I agree with you totally. And by the end, if a child is short, even though if he presents late and the epiphyses are, and he is going into puberty and the epiphyses are open, I usually I usually give them the benefit of the doubt. But however, I educate the families, just I don't know how the response is. You're presenting late, the chances of response are really poorer compared if you're presenting early. And this is where it comes, doctor, there are so different schools. It's like if you use growth, where delaying puberty comes in, and you might use the gonadotropin releasing hormone therapy as adjuvant growth hormone therapy. And there are protocols. I usually follow one of these protocols in my clinic in these kids approaching puberty to give them more, if they are short and they're meeting their genetic potential and their predicted adult height is poor. I usually start gonadotropin releasing hormone analogs to try and delay puberty in order to give growth hormone more room to work and hopefully getting a better response. And by the end, I educate my families is we're trying our best. However, the response might be poorer, or it might not be to growth hormone, maybe to puberty. And I educate the families about that, okay, this is late, we started late, but we're doing our best. But the earlier we start is the better.
Okay.
I think this is the key. This is the key, including having the family on board on what are the expectations of the therapy.
I do agree with this approach. Thank you very much for this
Thank you.
interesting lecture.
It's a
Thank you very
pleasure.
much.
It's a
It was
pleasure.
very nice.
Pleasure.
Thank
Take
you.
care. Take
Okay.
care.
We came to the end of this session, and there is another important session which is coming soon. Thank you very much for your attention. Thank you.